Hi everyone, this is Dr. Catherine Palmerola, and I'm one of our IVFMD physicians out of the South Miami office. I'm one of 12 to 13 docs, and while I'm based in South Miami, we see patients all over Florida, all over the United States, even internationally. We have telemedicine to help see everybody. I'm going to be joined today by Dr. Duro, who I'm going to help join in right now, which is very exciting, addressing any questions and topics regarding fertility and also acupuncture. So Dr. Duro is going to join us now. Hi.
Hi.
Duro, how are you?
Good. How are you?
Good. Great to see you. Happy March.
Yeah, you too. I know, it's going fast.
It's going fast. Well, January, February, slow start to the year, and then boom, suddenly it's March and we're off and running. How are you?
Great. We had some good questions tonight, I was noticing, so I was just looking over those. So we'll be looking forward to answering them. But as always, you guys are welcome to comment below. And I was going to mention that you're going to be in one of the episodes of our new podcast, which is our Q&As that we've done throughout the year. So these are now on, it's called Fertile Conversations. So if you guys haven't checked it out, please do, because we actually have the best highlights of our Q&As on Apple and Spotify now. So
that's
yeah.
I was going to ask you about those. I've been seeing some of the ads about your fertility podcast. So I was going to ask if you could share more about them. That's amazing.
Yeah, it's great. And we actually have, we've put the questions into a format where people can search now. They can see kind of, there's so many things we talk about. When I was listening to some of them, I was like, wow, this is such good information that I wish that we could, have everybody just be able to hear this who needs it. And unfortunately, unless you're on social media, you haven't really been able to hear these Q&As as much. So hopefully now, it's if you guys have friends or family that are not on social media or not on Instagram who want to hear them, you can just share them on. We actually just posted one on our story, but it's in our bio and IVFMD as well. There's a link there, so please share it. Really excited about it. It's one thing I wanted to do for a while.
Yeah, well, congrats on putting that together, and it's going to be a really great resource for all, our IVFMD patients, but anybody who's going through fertility or miscarriage struggles. Really great resources.
Yes, definitely.
Well, this is our March Instagram Live addressing all topics regarding fertility, acupuncture, and beyond. I'm Dr. Catherine Palmerola from IVFMD South Miami office, and I'm joined by Dr. Duro, who's acupuncturist extraordinaire. We had some questions sent in, which we'll address, but as you're listening in, feel free to post questions in the comments, which we'll get to. If you're joining us late or you missed something that was said, our video will be uploaded to the IVFMD page, so you can reference it or listen to the whole thing at another time.
Definitely. Great. Perfect. Yeah, and we can, I know we had a few questions in Spanish as well, so I don't know if you want to tackle that in Spanish or English, and both.
Well, yes, I had to translate them, but I can absolutely address them in Spanish. So we can start with some of the questions that were sent in. Excuse my Spanish pronunciation, but ¿qué tan seguro puedo hacerme ultrasonidos? Y quiere saber que el bebé está bien. In other words, so this patient is asking, how often can we get ultrasounds done? So, en español. Cuando tú estás embarazada, normalmente la primera ultrasonido es cerca a mínimo like 6 semanas. Cuando es más temprano de eso, 5 semanas, es duro por saber que es una embarazada normal o no. So a las 6 semanas, normalmente puedo mirar un sac, un gestational sac, y también el yolk sac. Y dice, ok, bueno, la embarazada es adentro del útero, no es un ectópico, no es un, no puedo, dice 100% no es una pérdida, pero si mirar un sac adentro del útero con un yolk sac, bueno, es una embarazada adentro del útero. en las primeras semanas de la embarazada, a veces a mí me gusta mirar cada semana, ¿ok? Necesita a mínimo una semana por mirar el bebé en crear a mínimo, ¿ok? Si es cada día, no puedo saber si es en crear. If we do it too frequent, if we do ultrasounds too frequently, it's difficult to know if there's true progress. So a mínimo una semana por mirar que el bebé en crear. Y la primera trimestre es la más riesgo por pérdida. So, en mi oficina, especialmente con pacientes con pérdidas o después de un transfer, a mí me gusta la primera ultrasonido. Normalmente es cerca 7 semanas, pero mirar 7, 8, 9. Otro doctor dice, ok, solo 2 ultrasonidos es necesita antes de mirar tu obstetricia, pero yo saber que muy pacientes son nerviosos y que quiero mirar al bebé, cada semana por seguro que todo es bien. So a mínimo 6 semanas y es posible cada semana. Now, si tiene sangre o un problema, bueno, puedo mirar más temprano de una semana, pero normalmente necesita mínimo una semana por mirar el bebé en crear. En inglés.
Wow.
I've been working at it. So the question is, how often can we do an ultrasound? And, normally we wait until at least 6 weeks to see a gestational sac and yolk sac within the uterus to know that, yes, this is a viable pregnancy inside the uterus. Before 6 weeks, maybe we see a gestational sac. It might be difficult to see the yolk sac. So waiting for that 6 week can really give us a better definitive understanding of the pregnancy. And then it is best to wait at least 1 week between ultrasounds to distinguish clear progress. Doing an ultrasound every day won't give us a true sense of is the pregnancy progressing, but within a week, we expect certain milestones to be met to help us know that the pregnancy is going appropriately. So certainly for patients that have had miscarriages or who are going through IVF or going through any fertility treatment, usually anxiety levels are high and it can be reassuring to look on ultrasound. So I'm more than happy to look on ultrasound every single week, 6 weeks, 7 weeks, 8 weeks, 9 weeks. And then at least in our fertility office, at the 10-week mark, that is when you should be with your OB/GYN, and they'll start doing important tests and monitoring the pregnancy and determining how often you need ultrasounds at that point. So a long answer for that question, but I understand wanting to look as often as possible, but a minimum, we need to give it about a week in between.
Yeah, definitely. That's so important too, to have that for reassurance for so many patients that have gone through multiple, pregnancies, IVF cycles. So they really appreciate being able to see that.
Of course. And, early in pregnancy, you may not have any symptoms. And sometimes that scares people. Sometimes they wish they felt nauseous or they wish they felt something to reassure themselves that the pregnancy is still there. But so ultrasound is sometimes the only reassurance we're able to provide. And I'm happy to do that. Una otra pregunta en español. ¿Qué pasa si mi esposo diere positivo a Fanconi anemia type L y hereditary hemochromatosis type 1, a igual de que yo en mi invite exam? So this is a question about the genetic screening test and testing positive. So un screen por un gene, si tú tienes un gene, un copy de un gene, normalmente no causar síntomas, no es peligroso por la vida, por la persona que tiene un gene. Y usar este prueba genético por seguro que la mujer y el hombre, o la mujer y la donante, o el hombre y la donante de óvulo, no tengo el mismo genes, ¿ok? Si los dos tienen si la mujer tiene un gene y el hombre tiene el mismo gene, tiene riesgo por el bebé. So, en este caso, normalmente recomendarme hablar con el equipo genético por más información de este gene específico. Por ejemplo, hereditary hemochromatosis, actualmente es un problema médico de la sangre, pero normalmente tengo tratamientos por este tipo y normalmente no es causar un bebé muerte o problemas de pensar, like, este tipo de problema actualmente no es muy peligroso. Pero si tú y tu esposo tienen el mismo gene, la primera cosa es hablar con el equipo genético por más información de este problema específico. Y si es un problema muy grave, bueno, es posible tratamientos por seguro que el bebé no tiene eso. Si es un problema que es poco a poco, no es muy peligroso, bueno, tengo esta información por chequear al bebé y seguro que tiene tratamientos médicos cuando el bebé nació. Si tu esposo y tú tienen genes diferentes, actualmente no importa, ¿ok? No causar problemas, no es peligroso para el bebé. So this was a question about the genetic screening and if the spouse had certain genes, what does that mean? So the purpose of the genetic screen is to confirm that the sperm source and the egg source do not have overlapping genes. Being a carrier for a gene in most circumstances doesn't cause that person to have symptoms or affect their life. I now have to say that with a little asterisk because certain genes we are learning actually, maybe this gene for cystic fibrosis causes an increased risk for pancreatitis. Apparently, we're learning more and more about genetic information. But in general, being a carrier for a gene does not affect your life, is not dangerous. And we do the genetic screen on both the egg source and sperm source to make sure that they're compatible. If there were an overlapping gene, depending on exactly what gene that is and what condition that gene causes, that might be just information to tuck into the back of your head for when your baby's born, and maybe they need to see a blood doctor or hematologist for monitoring, or so, maybe not such a bad gene, or if there is a really bad gene that both the sperm source and egg source have, then there is a concern for the health of the baby, and we have certain treatments that we can do. So if your first step would be to review these results with your genetic counselors and your doctors to know, is there a concern here? Should we have further counseling? Is there a specific treatment that's warranted?
Oh my God.
Yeah.
Yeah, so they're very difficult sometimes. I mean, that's with the whole thing going on with, with IVF across the country, and people getting upset about, not being sure, like if their state, where I'm from in Alabama, there's a lot of issues, obviously, where maybe you can't do frozen embryos or something. This is so important for genetic screening and all those things. If that's half the treatment there. So hopefully that resolves, and I understand why people are nervous about it, so
genetics is one of the areas of our field that has progressed rapidly, even in the last few years. When I was in my fellowship training, we were doing a genetic screen for 100 genes. Then it advanced to 280 genes. Now we're doing a gene screen that encompasses 560 to 580 genes. Wow. And definitely on the horizon is going to be the ability to do whole genome sequencing, which is going to give us tons and tons of information, hopefully helpful information and not confusing information. But genetics is definitely an area that's advancing rapidly.
Definitely, yeah. I know it used to not be so common that everybody would get, genetic testing on their embryos, and now it seems that it's much more common because you can find out more information, I guess.
Exactly.
More accurate. Let's see. I think you have another. Well, it looks like a follow-up in another question for the same person. Okay, I don't know if you answered that. Fanconi anemia.
Part of the same question, so I answered those together.
Okay.
But another one was, why isn't my IUI working and I ovulate each month? So this is a great question. You know, not knowing anything else about the person who asked this question, the chances for insemination working are very important depending on your other testing and age. So, you know, we want to make sure that both fallopian tubes are open. If we have only one fallopian tube open, that's going to decrease our chances if we have eggs that can only really be accessible from one side. How are the sperm counts? Do we have excellent sperm counts, or are they just barely meeting the criteria for insemination? Ideal counts for insemination, I say, are about 5 million moving sperm, but we need a bare minimum of 1 million moving sperm. So if we're hovering around that 1 million mark, you know, this might be a sperm factor. If we have other conditions like PCOS or endometriosis that might, or diabetes or blood pressure or cholesterol, all of these other underlying conditions might be impacting the quality of our eggs. And then very, very, very importantly is age. And unfortunately, the success of IUI is greatly linked to age. Typically, we see best success when we're under age 35. After 35, we start seeing changes to the quality of the egg that can be decreasing our chances of success. Even if all conditions are ideal, you know, we're young, we have good sperm, we have open fallopian tubes, we don't have other medical conditions present, IUI success is roughly 20 to 25% at best under those ideal circumstances. So unfortunately, it's a treatment that sometimes we do need to try several times, because statistically it is successful only about 20 to 25% per month. So if, you know, certainly if you've done many rounds of IUI and it's not been successful, it's time to regroup with your doctor and talk about, you know, was this ideal? What was suboptimal? Have we given IUI a fair shot? It's time to go on to something else, or is there something that can be tweaked to optimize our chances with IUI? Do we need to switch medications, increase the medications, do something differently to give ourselves a better chance? I like to regroup with my patients after, say, 2 to 3 cycles if we're not pregnant. One, because they're usually frustrated at that point. And maybe we haven't seen each other face to face for a few months. Most of our monitoring is done by our nurses, and I review the results, but maybe we haven't seen each other for a month, which can be scary, and they might, you know, a patient might be unsure of what's going on. So if we're still not pregnant after the second or third try, it's time to regroup with your doctor and see what else can be done to improve our chances. And maybe the answer is actually it looks perfect and we should continue trying, or often there's something that we can tweak.
Definitely. And you know, it's frustrating because it seems like in theory it should just work right away.
No, I know. Well, I tell my patients all the time, if only we knew how to be mice. Mice, they could get pregnant like 100% every month with 10 babies. And humans, we're a little bit more complicated. So we have to figure out how to become more like mice and make our embryos work better.
Not the most efficient reproductively.
Exactly. But I think it's
that was asked earlier that I had my egg retrieval last week, and one of my embryos, they said it was not able to be biopsied, but it was able to be frozen. Would this still be a viable embryo to transfer? She's asking.
Absolutely. So if it was frozen, that means it met criteria. It met the criteria to freeze. The biopsy is a mini surgery on a mini human. And in order to qualify for biopsy, at least in our lab, it has to meet the highest standards. So nice big embryo with sufficient cells, sufficient quality cells in order to tolerate that biopsy. If an embryo is developing appropriately, but maybe it's a little bit small, or maybe the outer shell, those cells are uneven or look fragmented or fragile in any way, then the biopsy might in fact damage a perfectly good embryo. So I always, you know, while we would love to know the genetics and we plan to do the genetics for a specific reason, and not having the genetic information can be frustrating, that does not mean that that embryo can't result in a successful pregnancy. If we don't know the genetics, then we revert back to age, and the success of that untested embryo is linked to age. If you're very young, it has a high chance of success. If you're older, then depending on the age, that will dictate the chances that it's normal versus abnormal. But untested embryos result in beautiful babies all the time.
Yes, for sure. And someone says ultrasounds were like going to the ice cream shop for me during my IVF pregnancies. That's great. That was a
wow. I'm not sure what that means, but
he was going excited to the ultrasound every week, so it's like a treat.
Yeah, and you can, you get more information and reassurance that everything's working and going. So I love ultrasound. Sometimes they can be a source of stress for patients. If you didn't have anxiety and OCD before coming to see us, certainly monitoring follicle sizes, monitoring the ultrasounds can definitely give our patients anxiety. But I love it when a patient gets excited about those.
Mm-hmm. Definitely.
Yeah.
Question about, does an endometrial biopsy hurt?
Well, great question. So an endometrial biopsy, this is a check for inflammation in the lining of the uterus, or chronic endometritis. And it is not the most pleasant. I will be totally honest. It is uncomfortable. It's typically fast, and it typically results in really sharp period-like pains, or worse than period-like pains, that are most intense while the biopsy is being done, and then you recover over, say, the next 5 minutes. But it is, on average, an uncomfortable test. So I always recommend taking some ibuprofen before that exam. So if you can take ibuprofen or Advil or Motrin, I would take like 600 or 800 milligrams about an hour before, and that can help reduce your cramping. If you can't take Motrin, something like Tylenol can help. Probably something like acupuncture could help. And then for my patients who are really nervous about these types of procedures, I even would prescribe them a Valium to help produce, stay calm and help them with that procedure. But yes, on average, the biopsy is a painful procedure, unfortunately.
But painful, but helpful.
Exactly.
There's so many uses for it.
Do it if we didn't think it would give us some useful information. Inflammation in the lining it can cause very painful periods. It can cause very heavy periods, but sometimes it actually causes no symptoms at all, but can be linked to either failed implantation of embryos or miscarriage. So it is something that I do look for before embryo transfers, or if there's particular risk factors present. So another question was, does a good day 7 post-ovulation progesterone also mean that there's good egg quality in that cycle? Oh, I wish I could say yes. It's certainly a good sign if you have a good progesterone level. That means that, you grew an egg, the egg released, and you ovulated. And now the ovary is working appropriately to make progesterone after ovulation. So we learn all of that information from an adequate progesterone level, but it unfortunately does not reflect on egg quality. The test for egg quality does not exist. I wish it did. We don't have a blood test. We don't have an ultrasound study or an imaging study that will tell us egg quality. We simply assume based on age and underlying medical conditions. So good progesterone level is excellent, tells us nothing about egg quality. And conversely, let's say you had a low progesterone level. That also does not tell us egg quality, but rather, maybe the ovary is not producing progesterone after ovulation as well.
Yeah, I was reading somewhere they were working on a medication to improve egg quality, a treatment for egg quality. I think it's by injecting into the ovaries and that sort of thing, but it's not here yet. But they were testing it on cats. They're using it as like cat birth control or some feline birth control. But
I mean, that was holy grail if we could figure out how to improve egg quality definitively with like a pill
And
or an injection.
actually, it was AMH that they were using, which is interesting. So, so who knows down the road if there's going to be a direct treatment to de-age the ovaries? I think so. Like, and
That would be awesome.
yeah,
Yeah. Yep. Um, if we could either slow down the pace of egg aging or stop it or reverse it, that would be unbelievable for sure.
definitely. Um, then we have a question about, I believe it's referring to acupuncture, when to do it before transfers. Does it help grow my lining? Is that, I think, is it about acupuncture there or I'm not sure.
I would interpret that as an acupuncture question. Yeah.
Okay.
So when is it best to do acupuncture?
I wasn't sure if it was progesterone I was referring to or acupuncture, but maybe we can answer both.
Yeah, sure.
So I'm not sure.
So from the fertility perspective, progesterone is used after the lining has thickened up for embryo transfer. We would use it in order to start exposing and transitioning the lining to get it ready for transfer. So the timing of progesterone and the timing of an embryo transfer are critical. Starting it too early or too late would absolutely impact the success of the embryo. So it's used at a very particular time in a transfer cycle. It does not actually thicken the lining. It, in most cases, actually condenses the lining slightly. Estrogen is what helps to thicken the lining in preparation for implantation or for embryo transfer. And then progesterone results in all of those nice glands of the lining kind of secreting their materials, secreting the nutrients, and getting it ready for pregnancy. So as a result, sometimes the lining often actually shrinks or condenses after starting progesterone, which is good, which is a good thing. And I'll leave it to Dr. Duro for the acupuncture aspect of this question.
Yeah, definitely. We know that acupuncture helps improve blood flow. They have monitored this through Doppler, and they've seen patients who have thin lining. They actually improved by a couple millimeters sometimes when the patients added in electroacupuncture specifically. So that one, we definitely try to use that if we know someone has a history of thin lining, or if they have really scanty periods. Sometimes they say, oh, I only bleed for 1 or 2 days. So it's like, to us in Chinese medicine, we say, well, let's work on blood flow, since, it could be estrogen deficiency, it could be many things, but we want to think about treatments that we can do ahead of time to help prepare them before the transfer. So if we can start that a little earlier, we try to do that around like 4 to 6 weeks prior to the transfer, starting to kind of add in those types of treatments, maybe some fertility massage, maybe some L-arginine, beet juice, things that we know can help naturally improve blood flow, along with stress relieving exercises, yoga, that sort of thing too. And I think in general, we still continue it after the transfer, not the electroacupuncture part. It's a different type of acupuncture, but we're also supporting the patient throughout, beyond transfer. I think that it's, a lot of people say, oh, just do acupuncture on the day of transfer, and that's good. It can be helpful, but actually I was looking at the statistics of, because somebody asked me that actually today earlier, what if I just do acupuncture the day of the transfer, which is fine. And I think that's definitely a good thing. But it's not quite the same as actually doing it beforehand as well. So actually I was going to post this and I didn't have time to do it. It was a study that they did to kind of compare, is it dose dependent? Like, does it matter if you actually have more than one treatment? As far as what they found, is that if you just did acupuncture on the day of transfer, it was an increase of 17 to 30%, depending on if you're a patient who has had IVF failures.
Oh, wow.
So had failures before, it actually increased your success rates more than the patients who never experienced a failure.
Wow. So 33, that's an incredible increase.
That's a good number. And if you're actually looking at the number of treatments, they measured the clinical pregnancy rate in this study. So I don't know if we have a take-home baby rate, but if the patient received 3 to 4 acupuncture treatments or greater than 3, then they had a 50 to 60% increase in clinical pregnancy rates.
Wow.
So that's a pretty big jump, I think. we say like, I mean, there's many different ways to measure acupuncture. Some people think we can measure it with sham acupuncture, which is very controversial. It's not necessarily inert. So you can put a point on a different part of the body and changes are going to happen in the body. Might not be the one that you want, but something's going to trigger something.
Right.
So not a great way to study it. It's mostly just if this group had acupuncture, this group did not. So we try to work on, our goal is usually 9 to 12 sessions if we can, because there are studies that actually show that definitely improved the actual take-home baby rate, not just
Wow.
the rate.
And that 9 to 12 sessions is over a period of how long?
Twice a week, usually for anywhere from like 6 weeks prior to stimulation or during. So these research studies actually it included the day of transfer as one of those treatments. So that's kind of when, we think, I think it depends on the patient, obviously, like, is this patient very anxious? Do they also need, help with that as well? We definitely see a difference in stress levels, and we know cortisol can play a part in hormones, no matter how you look at it. We're just not meant to produce babies on a fight or flight mode as a species, I don't think so. So we want to look at, how can we help the patient best, and if they need, more acupuncture prior to, or if maybe a few treatments would be fine. Everyone is different. So that's kind of when, the question was when to start acupuncture, before egg retrieval or before FET, or when is that? If you're stimulating, we definitely want to see you during stimulation, because your body's working very hard. There's sometimes side effects to these medications where some patients, have bloating, or they feel like headaches from Lupron, or those sort of things. We can help with that. But so, if they're having issues responding sometimes with the medications, they're, trying to get not as many follicles, but a good response to the medications. And sometimes just helping a little bit with the circulation, helping with some of those points that we do during STEM, that can actually make a difference. And sometimes we ask them during, treatment, how was the ultrasound? Oh, they found a few more, or there's some little ones that actually caught up, or those sort of things. So, we hear it secondhand. We don't have an ultrasound in our office, but I think it's really, throughout the years, it's been helpful as far as if somebody can do acupuncture during STEM. So what is your take, or what have you seen with that?
I mean, I'm a huge proponent of acupuncture. Sometimes the limiting factor is that these patients our patients are having so many appointments. They're taking a lot of time out of their schedule. So acupuncture sounds like one more appointment that is time consuming and stressful. So I say I never want this to be a stress, but actually acupuncture can be a huge anxiety relief and a safe space during this otherwise overwhelming time. Everybody asks me, how often should I be going? And I always say, I leave it up to the acupuncture. They are the expert. But depending on whether we're in STIM versus preparing for STIM, they might have different recommendations. It's absolutely safe to do entirely through STIM, entirely safe to do while we're getting ready for transfer and after transfer. I'm really strict with their activities after transfer, but acupuncture is an acceptable post-transfer activity that can absolutely be, I always say, at a minimum, it can be stress relieving and calming, which can only benefit us. But then there are many other potential benefits of acupuncture. So I love it. I encourage, especially when we have patients with very, very low egg reserve, or we've done a treatment where egg quality has been poor, I strongly encourage acupuncture, but it can be a benefit to everybody.
Definitely. Yeah, it's great that, also that you're telling patients, because sometimes they say, oh, I treat patients from different clinics from all over, and they're like, nobody ever mentioned this to me, and
Yeah.
it's like, it's frustrating. So I'm like, well, it would be great, on, maybe the first round to even mention, like, this is an option that you can do that would, be helpful if you could do it.
Yeah.
And not everybody can do acupuncture, or they maybe don't have the time, or not able to do it. But even once a week, we are, on Saturdays, we have a lot of people come in kind of relax because they're able to
Yeah.
get to the clinic stressing about getting to work.
Yeah.
And now we have doing the interlipids, so they do acupuncture with interlipids. So they actually knock that appointment out at the same time as the interlipids,
Yeah.
which
Can you
and
speak a little bit to, so I have a few patients that are needle phobia,
yeah.
totally um, turned off by the idea of having needles. So yes, they're really, really, really tiny, but can you speak about acupressure or cupping or some of the other techniques that might be used instead of needles, and are they just as effective?
Um, yeah, definitely. Sometimes we use auriculotherapy, which is just like, they look like little tiny
Little,
little ear seeds. Yeah, you probably see them because we use them during the transfer, because that's part of the Pulse protocol, the IVF acupuncture protocol. But they're not needles; they're actually little ears pressure points. Those alone sometimes are really nice for anxious patients or people that are having, pain or nausea. Actually, we use it for that, headaches. So those you can do if you. But I would definitely. I mean, we definitely start with patients face down. They don't see the needles whatsoever during the first treatment. That's just, I
yeah,
think, because we need to ease into this. It's
yeah,
like, it's very, different type of treatment. People are not used to this. A lot of times they've never had acupuncture, most people that come to us. So even though it's been around, 3,000 years, it's not the normal type treatment that you grew up with, in the United States typically. So that's where we kind of start, and most people are like, "Did you do anything? I don't even feel,"
huh?
like, um, and then they're also having to face the fact that they're going to be using a lot of injections if they're doing IVF. So we worked with a doctor many years ago who would actually send the patients that were needle phobic to acupuncture to help
I
the
mean,
fear.
that's a that is a good strategy.
Because by that time they were like, "Oh, I'm
Yeah,
fine," it's like it's kind of getting over that. But a lot of times it's the size of your hair, so they're 30 gauge, I mean 20, let's say, yeah, 34 gauge. They're so tiny, so it's very, very thin. But the word needle or puncture gets people a little bit nervous, so I understand. So we try to work with that, but we also, have a massage therapist who's wonderful at helping with, like, we call it fertility massage, or just, working with like massage to the legs, the lower back, sometimes some light massage with the abdomen. That's just sometimes very nice to have when you're also kind of easing into the idea, like, maybe I should try acupuncture, but right now I'm a little nervous, so I'll just do, massage or that sort of thing. That's totally fine. And then I have a little acupressure video. I think I posted a while back, but there are some acupressure points you can do at home that are also helpful. But acupressure hurts a lot more than acupuncture, I'll tell you that, because you have to go really deep. You have to
mm,
press till actually it's painful.
oh
So
wow,
it's demonstrated. They're like, "This is acupressure. Okay, this is
this is
not."
paper. Oh, I didn't realize that. That's good to know.
Yeah,
uh, oh, interesting.
yeah,
Interesting. But yep, just to know, it's good to know that there's other options or strategies if needles are a major barrier.
yeah,
Nice.
for sure. Always Chinese herbs. It's just that we don't usually do them during an IVF cycle, and they can, perhaps interfere with the lab work, or, you're measuring a lot of estrogen levels. They're phytoestrogenic, a lot of them. So we just want to, do those if you have plenty of time and you're not even on any medications whatsoever. You're like, sometimes people come in 3 to 6 months before they even start anything. It's like, okay, let's try to help with your cycles. Let's do that. And we can, if they don't live in Miami, we can just send them home with herbs, and for a month, and they kind of, you feel better, their cycles get better. Sometimes they get pregnant, which is nice. And then, we have time, but obviously that's not something that we have when patients are starting IVF. Usually if they're just coming in like, "Okay, I'm doing my stem tomorrow," it's like, what can we do, so. And then they're working with your nutritionist, which is great. A lot of times they're already on a supplement plan, so we're not changing anything there, just, kind of working with them on that.
Yeah, amazing. And I also think it's important to know that just like medical doctors, I'm a fertility doctor and I don't know much at all about your head or your neurology. Similarly, there are acupuncturists that are specialized in fertility, like yourself, and others that maybe have another area of expertise. And so I would, if you're already seeing an acupuncturist, I would inquire about their experience with fertility patients. And if they, if they don't have experience in that specific area, it would be worthwhile trying to find, if possible, a fertility acupuncturist, because they, you have various areas of expertise just like medical doctors do.
That's a good point. Yeah, and a lot of people, I'd give them a reference to go to the ABORUM website. That's a really good one. The ABORUM is a association that, we, as reproductive acupuncturists, we take an exam, we get certified through them, and we have to take RCUs every year in reproductive medicine, whether it's ASRM or it's, a seminar we did or an acupuncture fertility course, that sort of thing. But it's just kind of just to say, look, we do understand, we do speak the language, we work with IV a lot, we work with pregnant patients a lot, so we're able to see you, and I would feel comfortable, with patients who are, maybe moving somewhere else, or they're going to an IVF transfer in another city, and they can just look on the website, and we call them, and we're all kind of, on the same wavelength. So
Really helpful.
Yeah.
There was another question here about how much does weight affect fertility? And I would say it is important. With increasing weight, being overweight, obese, morbidly obese, there are often other medical conditions that come with that. So there tends to be higher diabetes, higher cholesterol, higher insulin resistance, and high blood pressure. These other comorbid conditions that come with that increasing weight impact your overall body's health, and therefore the egg health, the sperm health. Especially in men, as men gain weight or become overweight, obese, we see lower testosterone levels, higher estrogen, and this is really impactful for the sperm production. So sometimes for men, weight loss to get into a healthier range, maybe if we're morbidly obese, aiming to get into a lower BMI range, will dramatically improve their sperm. For women, we can sometimes see higher impacts of estrogen levels in women who are overweight and obese. We tend to see higher levels of estrogen, which can have secondary effects on the uterus and how the ovary hormones are working. So it definitely is relevant. If there are not, let's say you are someone who is overweight or obese, and you actually don't have any of these other underlying conditions, I would say that's ideal. Then depending on weight, it can sometimes impact the efficacy of our treatments. So oral medications or even the IVF injection medications, depending on the level of or degree of being overweight, our medications are sometimes not as effective, or sometimes our monitoring and being able to appropriately see the ovaries and gauge your response impacts the fertility treatment, or impacts our ability to access eggs during an egg retrieval appropriately, or access the uterus for insemination. So sometimes weight poses a barrier to being able to best diagnose and follow you during treatment. And then finally, it absolutely has relevance to pregnancy health, because being overweight or obese becomes higher risk for blood pressure problems in pregnancy, diabetes problems in pregnancy, and ability to monitor the baby safely. So it's relevant, depending, for my patients who are just barely, we have these assessments of weight, body mass index, which is not perfect. And we have body fat percentage, which I think is a better assessment, but it is similarly not perfect. So falling into a specific number category does not necessarily make treatment impossible or make our outcomes terrible. We have to look at the whole picture. And yes, if you fall into the obese category, but you don't have any of those other medical problems we're seeing adequately, then I say, okay, let's focus more on, the quality of the calories that you're eating and your overall lifestyle, and making sure we're exercising, we're getting cardio, we're doing weights, we're eating the healthy foods, and we focus on that rather than a specific number. But if we're in, very high categories of weight, then it is a matter of simply getting you to a lower weight so that we can safely do treatments, effectively do treatments, and have a safe pregnancy. So it's relevant, yet we have to look at more than the number, 100%.
Is there an actual like maximum weight that, like, I guess for like anesthesia purposes, for like putting someone under, that
Oh,
sort of
so
thing?
at IVFMD, we are an outpatient center and we work with CRNAs. We do not work with anesthesiologists. So we therefore have to follow very strict guidelines to make sure that we remain a safe, accredited center. We had an inspection, I believe today or yesterday, and in order to remain accredited and safely perform these treatments, they make sure that we're doing things under certain guidelines. So we do have a cutoff for our anesthesia IVF procedures, or any hysteroscopy in the office, and that cutoff is a BMI of 40. That also happens to that's now become our network-wide cutoff for recommendation for IVF as well. There are other centers that may work in a hospital setting and have access to anesthesia and the ability to intubate and safely ventilate patients if they need it. And those are the centers that might be best able to handle, BMI over 40 in emergency situations where we don't have the time for weight loss. But yes, at our center, we have a BMI cutoff of 40 for anesthesia purposes.
Okay.
Yeah.
That's good too.
And the concern is, that the higher weight, it becomes harder to ventilate, under anesthesia. Your respiratory rate often is lower. Sometimes pressure on the abdomen just makes it difficult for the patient to breathe. And we don't have the support to, under an emergency situation, of course, we're going to intubate you and we can make sure you're breathing, but we prefer not to get into the emergency situation and do things safely.
Mm-hmm. Definitely. And so that's a good, that's actually, I didn't know the cutoff, because I know that the BMIs have changed through the years, like, but it's a source of stress for a lot of people I know, especially with PCOS, that are just told, like, just lose weight,
I know.
So,
I know. And it's important. It's more than just the number. I would say the other underlying conditions and your metabolic status and inflammatory status and your overall health. I'd prefer someone who's overweight but eating healthy, doing exercise, rather than someone who's normal weight but eating junk food and not exercising and doing none of that. So it's more than a number, but yes, there are relevance to health.
Oh, right, because we started early, because we start a little later with Q&As when we do them,
Yeah.
but I know tonight with Dr. Palmerola, we start at 6, so we definitely are going to repost it. And you can ask questions. Yeah. You have a few more minutes, so definitely ask away. So
we had a few more questions that were sent in advance, and I saw some questions that have been coming in, so I'll try to address them a bit faster. So BMI recommended for embryo transfer. At our center, we would say we absolutely should not be over 40, but it's in the patient's best interest to be as close as possible to 35 or below. When we're doing a transfer, our embryos are frozen, and time is not going to impact the quality of that embryo. So we do often have a rush and urgency to make embryos, but once they're frozen, we can relax. And other than the fact of, yes, wanting to be pregnant yesterday, if we need to optimize, we have the time and luxury that our embryo is going to be safe. It's not going to change, and our uterus is good for decades beyond menopause. So striving for a safer BMI will be in the best interest for your success for pregnancy. Mm-hmm. Struggling after a biochemical pregnancy, a failed second retrieval, how do I hold on to hope it will work? Oh my goodness. So sometimes these treatments are straightforward and super successful, and we slam it out of the park the first go. And for other patients, it's a really, really, really long journey. After, a biochemical pregnancy is devastating. This means a pregnancy that resulted in a positive pregnancy test, but then um, ended up having a miscarriage before making it to the ultrasound stage. And what I always try to say, I'm an eternal optimist, maybe to a fault, but any pregnancy is a positive thing because it means egg and sperm fertilized, it developed into an embryo, and it attached. At some point, the pregnancy did not continue and it did not develop, but we at least made it through all those very, very, very important first steps, which means we can do it again. Um, the failed egg retrievals are always devastating because so much time, work, effort, psychological investment, financial investment goes into an IVF cycle that when it doesn't work, it's just absolutely devastating. But that cycle gives us information, critical information about how your body responded, how the eggs and sperm combined, how the embryos developed, and we get so much information from an egg retrieval procedure that helps us shape and modify what to change. If the cycle didn't work out, we got to change something. We got to do something differently. Maybe it's our medications. Maybe it's optimizing another medical problem. Maybe it's doing additional testing to see and investigate something we weren't aware was present. This information helps us reorganize ourselves and determine a new plan of attack that can only do better. So it's really hard. Sometimes the answer is you need to take a little break mentally and psychologically and financially and emotionally from the IVF center or from your fertility center. Sometimes patients prefer to develop a new plan immediately so that they stay motivated and task oriented. But it is important to keep trying and stay on the path. And your path took a little turn, but you got to keep going. They have actually done studies that patients who stick with it, they are the ones that will succeed. Patients that drop out, it sometimes works, but it's the patients who stick with it that ultimately succeed. It's so hard at times, but my only recommendation is to keep an eye on the goal, the ultimate goal, and keep at it.
Yeah, I agree.
It's
Yeah,
so hard. Sometimes they feel like a pep rallier, but motivation and stamina and optimism can sometimes falter, and they're so critical to keep going. Yeah.
I used to work with someone who said you can either sit on the bench or get in the game.
Yeah, exactly. And they literally have studied patients who keep going with various cycles versus patients who drop out. And the patients that keep going, it ultimately works in the majority of cases.
Yeah. I agree so much too. I know. So we're rooting for you for sure.
You got this. Today, and so sometimes the answer is acupuncture to help with anxiety and stress relief at a bare minimum. I often am recommending, sometimes patients do have a therapist and that can help as well, but acupuncture is an incredible form of therapy as well.
Yeah. And definitely, there was one study about speaking of studies that it improved resilience. Patients that were getting acupuncture with IVF. So that's so important, like you mentioned, because every process is a learning experience, like you said, and hopefully you can learn really quickly. But I think that's what I love about you guys is you don't like keep spinning the wheel. You don't want to keep doing the same thing over and over. You want to figure out why something's not working. So that's great. Oh, we have a question on reproductive immunology.
Ooh, very difficult topic. Thoughts on reproductive immunology. I didn't pop on. Didn't have anything positive on recurrent implantation, APA, and K cells. We're still experiencing recurrent pregnancy loss, 4 losses. We addressed factor 8 and MTHFR with Lovenox and baby aspirin. Is there anything else to explore? So without knowing all of the testing, we think about many possible causes of implantation failure, but some nuanced ones are, is there some underlying metabolic or inflammatory derangement? And these can be sometimes nebulous, but there are various markers for inflammation that you can consider. Are you being exposed to any unknown toxins like mold or mercury or arsenic or lead? Sometimes that's an avenue to explore. If you have underlying conditions like PCOS or blood pressure or cholesterol, we need to optimize those. Has the sperm been fully evaluated? If we have good sperm counts, but it's fragmented sperm, this can be an avenue that can be explored. The field of reproductive immunology is so fascinating. I do not personally have an excellent understanding of it, but there are reproductive immunologists that do, various tests which are controversial, but sometimes give us information about the lining of the uterus and whether we have too much inflammation or too little inflammation, too much immune activation or too little immune activation, and sometimes that can help direct a best next path. So I think reproductive immunology is very interesting. I don't think we have all the answers, but I support my patients who explore seeing a reproductive immunologist, and I'm, open to considering their recommendations. And I work with some that I referred to in New York, and I often love to see the various reports with different information. So I wish we had all the answers, but I think reproductive immunology it's worthwhile exploring if you've had those many losses.
Definitely.
What's the latest age to make good, successful embryos? I had my first child at 39, and I would love to have a sibling, but I know I have to do a IVF. Very good question. And I would say it depends. It depends on how many eggs you have. And after age 40, quality of eggs starts declining rapidly. My personal oldest embryo I've made that's turned into a baby was 43. Okay. But I'm always asking my colleagues at these meetings, like, what's your oldest age? And that gives me hope that it can be worthwhile trying. So I've had colleagues with babies from 44, 45-year-old embryos, but typically that requires a big egg number in order to be able to identify the high quality eggs. So I would say beyond 43, we're getting it's going to be really hard. And whether it's worthwhile pursuing a treatment like IVF would really depend on egg number.
Yeah, definitely. And there's a question about endometrial biopsy. You see that?
So I've had a second endometrial biopsy after taking antibiotics. What happens if it still comes back abnormal? I can't even imagine going through a third biopsy. Agreed. So this can be so frustrating. Once we identify endometritis, depending on the amount, we do sometimes like to confirm that it's gone. Sometimes if it's minimal amount, I actually don't check again, but substantial amounts, I do like to confirm that it's been cleared. And it can be sometimes pesky and require a second round of antibiotics. If we're still positive after that second round, I consider looking inside the uterus with a camera to see if there's maybe something specific structurally that might be causing this inflammation, like little tiny polyps, or sometimes it can look very inflamed and red. Sometimes it looks beautiful and perfect. And you can get just visual information of, does this look inflamed and abnormal, or does this actually look perfect, by looking inside with the camera. And at the same time, I actually culture the lining of the uterus to see, are we dealing with a specific bacteria that might be resistant to our prior amount of antibiotics that we've been using. Endometritis, I don't typically think of as an infection. We do treat it with antibiotics, but when it's persistent, I do end up culturing the lining almost always it comes back negative, but it can help reassure ourselves that actually the lining looks good. Sometimes we're dealing with very particular pathologists, and their endometritis is detecting plasma cells. It's normal to have a certain degree of plasma cells in the lining, but endometritis is called when there's a high number. So maybe the pathologist is being a little bit lenient with their diagnosis, and looking inside with a camera can either provide reassurance or an explanation, and therefore a treatment.
Yes, I know, super frustrating though. I know it'll eventually resolve.
Yeah.
Yes.
Okay, so maybe there's 2 more questions here. Is it normal to spot on day 5 after an embryo transfer? And I would say spotting is never anticipated or normal, but maybe indicates implantation. But it's definitely something I'd reach out to your doctor. Maybe they want to check your progesterone levels or your hormone levels to make sure that they're adequate, and making any adjustments. So I would reach out to your doctor to just share that, and see if they want to do any testing before your beta test. Can you walk on a treadmill during the 2-week wait after a transfer? I would say no. Yes, you can do walking, but on a treadmill, I worry about falling and tripping, and I certainly have tripped and fallen on the treadmill all the time. So I tell my patients, you are going to be very gentle, and fine to do walking outside, but treadmills introduce this element of tripping and falling. So I would just be, walking is fine, but I would be mindful of treadmill, and definitely confirm with your doctor. Maybe they are more lenient. I just tend to be very conservative. So again, if you're joining late, this will be uploaded to our IVFMD page, and you can review all of the questions that's been asked. If we didn't get to your question, we're going to have many additional Instagram lives coming up with Dr. Duro. Otherwise, you can feel free to see us in the office or virtually. We're always we're able to see patients all over Florida, but we can also see you if you're out of state or even internationally, with virtual medicine. Dr. Duro is remind me again, your office is near the Cooper City location?
The border literally of Miami and Broward, so right off of 75. But we're in the office Tuesday through Saturday. We have evening appointments because I know a lot of people like to come after work, and we are able to work people in a lot of times when they're having their scheduling around the transfer or that sort of thing. Sometimes we can see patients the morning of the transfer in our office, or if it's in the morning in South Miami, I can usually go there to do acupuncture during the day of transfer. So, and also we have another colleague who does the treatments in Broward. So we try to help, and we're here for you. You can definitely also go to our bio and please follow our podcast. And there's a lot of good info from Dr. Palmerola, Dr. Gelman, Dr. Wood, many of your doctors there. I know they're trying to squeeze in the last question here, but okay, I see everybody's got their questions in. Great. So thank you guys. Thank you, Dr. Palmerola. This is also so helpful, and we appreciate it.
Awesome. Well, thank you so much for joining us, Dr. Duro. I'm going to upload the video to IVFMD's page, and I look forward to seeing you on a future live.
Great.
Have a great day.
Bye, everyone.
Bye.